Welcome, Iris.
Hi, Joe. How are you today?
Hello. I'm doing wonderful. Thank you. Thank you so much for joining.
Of course. Of course,
All
this will
right.
be fun for me too.
Absolutely. Well, everyone, welcome to Regeneration, a series about how people and communities evolve, endure, and carry the work forward across generations. Today, I have the pleasure of speaking with Iris Weil, a seasoned healthcare management consultant whose career has been defined by a deep commitment to community health and equitable access to care. As executive director of Healthcare LA, one of the largest independent practices in Los Angeles County, Iris spent almost 9 years building, advancing value based care models, and directly supporting federally qualified health centers throughout Los Angeles County. Iris continues that work through her healthcare management consulting and advisory support, including her work with Healthcare LA and the community clinics that are within that network. Her career span, I think, speaks for itself. And so today I'd really like to just have a conversation more so around your career trajectory, what keeps you invested, what keeps you committed to the work. Because as far as I know, Iris, you have a life that allows for you to be doing a lot of fun things, but I know the work is fun, right? So
Work has always been my sandbox. I've always enjoyed the work, and I've enjoyed all the professional people I've met along the way. So at this point, in terms of regeneration, I love mentoring people who are coming up in the healthcare world, management world for sure. Absolutely.
well, I had the pleasure of spending time with you a couple of weeks ago in Vegas and getting to know a little bit more about Iris and just really the influences I think that you bestowed on others and still do. The relationship I think that you have had with Alex, he always has spoken very highly of you. And the fact that you were the catalyst in a lot of ways to opening the doors within the FQHC space in Los Angeles County, I think that speaks for itself. And I hope that through the work that we do and continue to really be involved in it is something that you are proud of because we're very grateful for that.
Absolutely. I remember when Alex and I met, I really needed his help because Medicare Advantage was beginning to blossom throughout Los Angeles County, and the FQHCs they were not comfortable taking care of the elderly or the seniors because FQHCs, as we all know, got started with women and children. And many of their providers were not used to taking care of older adults. And so Alex softened the blow and started to meet with a lot of the CEOs of the health centers. I think it was around 7 years ago, maybe even longer,
Mhm.
2016, 2017, that he began talking to many of the health centers in Los Angeles County. They trusted him.
Yes, absolutely. I think the early phases of that work and just really the adoption into what it means to keep the patients in the health center, to educate the patients, that really is, what we are still doing today. It comes with a lot of education. I believe it starts at the top and really speaking to the leadership, ensuring that what we're explaining to them aligns with their goals. And more than anything, I think when we're ready to deploy projects or new relationships in that same framework of generational retention, keeping the patients connected and informed, it really can't stay at the top. The health centers need to bring that message and that organizational goal down to the front lines and across to all of the clinical staff, because without that buy-in from the staff, we see that there's a lot of
I
let's say
think
barriers and struggle.
The key word is the clinical staff, because a lot of their providers of family practice, physician extenders like nurse practitioners and physician assistants who hadn't had or still don't have a lot of experience taking care of the older population. So they have this fear and this unknown and an unwillingness to pivot to see what that would be like. So the onboarding of professionals in a health center, extremely important. And everybody needs to realize every touch point that a patient has in a health center is also a participant in their comfortable attitude to coming to that health center, to feel welcome. And every touch point matters, from the front desk
Absolutely.
to whoever takes them to an exam room, whoever is taking their blood pressure, the medical assistants, everybody matters. And it's a lesson I think still needs to be learned today.
I agree. And when we think about the work that you did with the value-based care models, really helping inform the health centers and shaping the strategy and just the resources from the IPA side of it, what did you actually take, or what did it actually take to build those models in a way that it worked for the FQHC clinics?
So value-based care was like saying an expression to leadership, and they were like deer in the headlights. Like, I always provide good care to my patients. Well, what does that look like? I would ask. So again, it's making them aware of all the required screenings that patients from, I always say, from cradle to grave are necessary, and encouraging a patient to do that. And depending on the demographic of that population, again, cradle to grave, there's a disparity in understanding why these screening tests are necessary. And so educating everybody, including the patients, was important. One of the important things I think I did early on is we hired a bank of patient navigators. Basically, only job was to reach out to patients, women, men, to encourage them to go in for screening tests. For example, women, and depending on the patient demographic of the community, were afraid of going in for mammogram because it hurts. Well, there is some uncomfortable moments during the screening, but it's so necessary. And the earlier you educate them in getting screened, the better outcomes as a patient you will have in the future. So educating the masses, men were fearful. I don't do that. In the Latino community, for example, the machismo attitude that a lot of men have, they didn't want to come in to see a doctor. That showed weakness, and they didn't want to feel weak. And we had a provider back in the day who would educate physicians, male physicians in particular, on how to communicate with a man about the importance of all these screening tests. It was very interesting. It was a good study at the time. So that's something that we did. And I met with everybody in a leadership position face to face, going over the data, going over the required screenings, why they were so important, what time of year they should focus on calling out patients and bringing them in. It was a lot of work, but it was building relationship. And then in 12 months' time, when they see the bonus dollars that were available to them and coming to them, all of a sudden a light bulb went off and said, Iris was right. I would send out emails saying, did you look at this? And, finally they said, it made sense, Iris. Look at the dollars we got. It's like, hello. So that was an important component of it, is really making the audience, and it was a large audience, awake and aware of the importance the value-based care opportunities presented. In addition, in the FQ world, it created another visit. PPS rates, that was important. So when they finally understood it was a win-win, not only for the patients, but for themselves, and elevating health status in the communities they serve, traction began, results started to show up, the efforts started to pay off, and we are where we are today. One of the things I was most proud of in my role in leadership of Healthcare LA, we were always in the top third of performance in value-based care, with the largest a Medi-Cal plan in Los Angeles County, LA Care, which was, a great feeling to know we were in the top third. And I wasn't a problem because we were an IPA in the underserved community. So it was really special at that time.
And the work continues,
And the work continues.
yeah, there are a lot of misconceptions. I think you called out a few, whether it lives on the patient side or, internally within the health center itself, when it comes to treating the, longevity of a patient, whether it's a baby or an elder adult. I think you hit the nail on the head, and I really value the approach and just the sensitivity around something that rings in my head because it just I keep on hearing you. They don't know what they don't know. They don't know what they don't
They
know.
don't.
And that allows for us as, consultants, advisors to really help bridge that gap, to help bring in that understanding. And healthcare literacy for the patient is something I'm very passionate about. But I believe, what you're speaking about too is just bringing that information and ensuring that the entire set of stakeholders on all ends understand what the upside is to getting your screening if you're a
Yeah.
patient or providing the screenings and information.
Exactly. In the early 2000s, so a long time ago, the letters that would introduce this subject of values-based care to members, simple, as they didn't understand it. The language used in letters was above their level of education. And we had to rewrite many outbound information cards to a junior high school level of reading because the basic education for the populations we were serving at the time, many of them didn't make it to high school because of economics in the communities in which they lived. They had to go to work. They didn't pay attention, sit with their kids doing homework because they had to work, the parents. So we had to rewrite information, education, patient education materials at the junior high school level to get the attention of the patient population. And also, again, working with the providers to understand the commitment their health center made to the health plans so that patients would stay enrolled or join up and grow the health center from the health plan for the various payers from LA Care to Anthem Blue Cross to Blue Shield to Molina. There were a lot of administrative responsibilities they weren't familiar with. And then we introduced Medicare and Medicare managed care and the STAR measure requirements for seniors. Well, maybe a little more intensified. I think at the time there were 41 STAR measures and 19 value-based care measures in the commercial and Medi-Cal arena. So when they heard the word 41, well, some of it was pharmacy. They wrote a prescription that took care of that measure. So again, it's complicated, but it's doable, but you have to invest the time. And I think that's the most important part of it. Invest the time in your workforce. Yeah.
And yeah, and there's something that I think can be said for the letters, really ensuring that their language capability compatible and the verbiage is, simple and plain. But also, I think it really compounds and highlights the fact that having those conversations in clinic are of value. And so, I was thinking about like just the relationship, that is built at the time of care. The person answering the phone to schedule the appointment, or the front desk that's checking you in, the eligibility checks that are happening before you even see the provider. Those touch points are so valuable. And when the clinic is really in sync and in tune with all of the goals and, getting those patients in and advising them on, gaps in care, or you're turning 65. We have a resource that, we'd like you to speak to regarding your Medicare options. All of those touch points, I think, add to the buildup of attaining those goals, because you get that patient when they are in such a mode that they're going to lean into the trust that they have with you. And when those conversations are missed, or, the front desk is a little bit too busy, or, compounded with other things, it's a missed opportunity. And so you have to rely on letters that may go unopened. So,
I fully agree. The other thing that's intimidating is we were brought up, a doctor. It's like the highest level of education and on a pedestal. And how do I relate to this person? And can I ask a question? And softening that and saying that's why the doctor is there. They want you to ask questions. They want to know more about you. It's important to ask questions so you understand the reason for your visit and how you could be cured for whatever ails you at the time of that visit. So the myth that you couldn't ask questions back in the day of providers was a horrible barrier, and that barrier has to be broken down still today. I think it's really important. And again, we need to be sensitized to the fact that when patients come to a physician, more often than not, they're not feeling good, and they're not, their attention span is pretty small, and we need to speak slowly, make sure they understand, repeat the questions, repeat the care plan. I think the blessing now is care plans are printed out and handed to patients so they could leave and review what was discussed at the visit. I think that was the best thing that came out of implementing EMRs years ago, the care plan being handed to the patient.
mhm, mhm. Yeah, that way they can take it home, review it with the caregiver, refer back to it when they're feeling a little bit better. So definitely agree on that. As far as something else that you mentioned regarding the implementation of value-based care and the upside in terms of the incentives that, started becoming more of a aha moment to the FQHC leaders, what would you say would be, even today, would be some of the barriers that still exist in operationalizing a large scale initiative for patient education or outreach?
Some of it is staffing. Some of it is a referral process. What services are offered on site? What services have to be delegated to another location, and getting that patient from point A to point B. So that sometimes was a barrier. A lot of the patient population works. So how do we make those services available so they can get there without taking time off from work? That would be an important component to all of that. I think the value-based care initiative can seem overwhelming. And so what was recognized was a lot of the support staff or the patient-centered medical home, when they all got organized, what's called patient-centered medical home, and there was a care team, the team member, not the provider, can aid the patient on getting a referral for mammography, getting a child immunized and taking the children out of the mother's hand and walk them away and get their shots done, how we delegated those services out within the health center and the workflow so that the burden wasn't always on the provider 100% of the time. That has changed. So I think that's been a plus. That I think there's still a learning curve depending on the resources available in a health center, because we have large health centers and we have small health centers, and the ones that are small, they don't have as many resources as the bigger health centers that have 200 or 300, 400 employees makes a difference. So having the human capital available to guide a patient is very important. The healthcare system today is a complicated maze. It's not easy for the working population. It's even more difficult for the senior adult patient population. It's complicated, and it still remains intimidating. So I think we still have to be sensitized to all of that in leadership roles to make it easy for patients to get from point A to point B. Value-based care isn't complicated. It's really a learning curve for those who enter into the healthcare delivery system on any level, and it remains a learning curve for the patient population.
I agree. I agree, and I know that there's been more conversations, that, happen every day that, we don't get to take part in, that shape, how a patient is going to experience their care delivery, and all I can hope for is ease and just, as you mentioned, having that sensitivity around what is going to move the needle, what is going to really, I think, move somebody either to get a screening, to understand the benefit for them or the risk to not having a screening, making it a little bit more seamless to get that information so there's not so many barriers for the patient. But when we think about the aging population, which I feel very passionate about because I do experience my parents' challenges and you know, I'm here for them. They can pick up the phone and they can call me and they have their friends call me and they check in with me. Did you speak to so and so? Did you help them? And all of those multiplied by thousands, if not millions of other people that are confused and left in the dark and not really sure. If there's anything that we can call upon when it comes to FQHC leaders in respect to their aging populations, what words of wisdom or advice would you want to go ahead and offer at this time?
I think the senior population definitely needs patient advocates to address some of the challenges you were discussing that you do for your parents. Just taking medications correctly at the right times of day, the right dosage amount. It's complicated and there are more drugs on the market now and it's overwhelming. I've watched it myself. I've experienced it myself. So medication and medication reconciliation with a primary doctor over time, at least once, twice a year, I think is extremely important. Case management. Patients with chronic conditions, they need to be seen more frequently, probably 6 times a year. And sometimes access and availability is challenging in a health center. That's something that they have to monitor on a regular basis to make sure patients can see a doctor when they need to see the doctor. Also, having patients at this age bracket understand the triggers so we can reduce the use of emergency room use and readmissions to the hospital because they don't take the medication. They didn't see a specialist on time. That is terrible and that needs to be managed better. And I think some health centers, again, it's resource intense, but it makes a big difference in the long run. So the patients with chronic conditions, heart disease is still the number one killer of the elderly population in the U.S. What more can be done? Well, manage your patient. See the patient more often. Don't wait for the patient to call. Be proactive and bring that patient in.
Amen. Well, switching gears a little bit, I know you have a very fine hand when it comes to relationships. And when it comes to the payer relationship and the FQHC, what do you see more of now compared to what you saw in terms of just any assumptions or misconceptions? Or do you feel like the relationships are in a good place when it comes to resources and really just the understanding on
I,
both ends?
I think COVID, there was a real shift because COVID stopped everybody from visiting everybody. And that was a terrible thing, I think. I mean, it was necessary, I get it, but I don't think it helped in the business relationships. And so the health plan executives or even manager level, they are never on the ground in a health center to see the challenges that the staff, the providers face on a daily basis. All the health plan does is hand out an agreement and say, sign it, do this, review all the requirements, and let's go. It's not that simple. No two patients are the same. No two health centers perform the same. It takes a partnership. It takes ongoing communication. It takes visualization of looking at the physical plan and see if this makes sense from an operations perspective at a health center. The health plans don't know that because those people did not grow up in a health center or a medical group or a physician office. So they are just speaking anecdotally. It doesn't work. You have to actually see it. I think, Zoom has helped a whole lot because more people are Zooming and seeing each other more frequently so they don't have to travel and sit in traffic and wait for travel an hour for an hour and then travel back for an hour. It's not worth it. So I think having the visual Zoom interaction is helping, but it doesn't give you the full flavor of how a health plan is operating day to day, the physical plan, how patients come in a door, a crowded waiting room. What happens? That's complicated. And how do we make it simple for the patients? And I think health plans recognize the necessity of this workforce, but it can't, it's not, it could be better. I just met with a team and I encourage quarterly what we call joint operations meeting because the plan has expectations and the providers of care have expectations. And sometimes they're not swimming in the same direction. So quarterly meetings, what's working, what's not working, extremely important for this partnership to succeed into the future.
Agreed. Agreed. Now, when we think about an FQHC that has 6 different IPA contracts, and that we could see that there's operational constraints, and they may not be able to really meet all of the expectations within the contract when it comes to value-based care, what would be the top 3 recommendations you would provide to an FQHC in that situation?
First, I would recruit my finance department and say which of these IPAs are contributing significantly to our bottom line. Which ones am I more profitable with and which ones I'm not? And that would begin weeding out. And it's important to have a strong finance department. And as a consultant, data is knowledge. And if we don't have the data, we cannot make a decision. So real-time data is very important. And then relationship. Which of the IPAs do I have the best relationship? Do I get the best information? Do I have the best financial arrangement with? Lots of FQs signed contracts because they thought they had to keep patients coming in the front door, and maybe they did. But now that as time has passed and the relationship is, 3 years old, let's say, let's time to review what the terms of the agreements are. And do they still make sense for me compared to the other ones? And so going back to the file cabinets, pulling out those documents, reviewing them, look at your finance team. Are they recording receivables and expenses against that? And value-based bonus opportunities. That makes sense. And, I've seen many contracts and they say, oh, I've got great cap rates. And maybe you do, but what are you getting in value-based care? And it's like, well, maybe 25 cents per member per month. And what's your enrollment? Does that still make sense? Can you buy something? Can you buy a piece of equipment with that? If the answer is no, maybe it's time to move on. The challenge is from canceling an agreement with a particular IPA that has a certain amount of health plan. Technically, the IPA holds the agreement and the IPA really is responsible for the patient care. So if you want to move that patient to your other IPA, the patient really has to make that decision. You cannot, as a FQHC, you can tell them, inform them, I'm canceling my agreement with the pink IPA, and I would, I wasn't a good fit. Business is business. I like yellow. So if you feel inclined and you still want to come here, you call your health plan and you tell them you like yellow and you want to be with yellow. So it's a complicated process. A lot of planning has to go in advance of making that decision to trim IPA relationships. So it's not an overnight, but you have to start out with who is the best partner, who affects my bottom line the most, and go from there.
Great words of wisdom. Thank you so much. Now, to wrap us up, Iris, I just wanted to ask you well, first of all, thank you again. I have learned so much just in the short 30 minutes of our conversation. So thank you for reinforcing that. In terms of regeneration and you sharing the wisdom, your lived experience, your career trajectory, what would you want emerging leaders in this space to know that perhaps took you some time to learn?
Relationship building is important. You might think everyone's your best friend, but maybe they're not. And you only have your reputation. So what comes out of your mouth, the words you use matter. The follow through on a request is important. Don't over promise and under deliver. The worst thing in the world anyone could do. Have to understand these CEOs, the CMOs, the C-suite at these health centers are very business, and their priority is not your priority. But how do you link and integrate your priorities with them? And that's the hardest part, really. And timing is everything. So relationship building is key to a successful business, I think, and trust. And I was fortunate enough that I didn't gain, I earned, and I worked hard, earned the trust of the people I was working with, both on the provider side and on the payer side. Because if I promised something, I delivered. And if I couldn't promise, I provided adequate notice that I'm not going to be able to do this. I'm sorry. You got to be honest. So yeah, trust, relationship, your reputation matters because these people are going to show up somewhere else. And it's like, oh my God, now what? So trust and relationship. Yeah, very important.
Beautifully said. Thank you again, Iris. I appreciate your valuable time. And I welcome you back for more because I know there's always more to share and
Always.
more to come. So
It's
thank you again.
evolving all the time. Never, healthcare doesn't stand still, ever.
I'll quote you on that one.
Okay. Thank you.
Thank you.